This is Dr. Ihab Abdurrahman, consultant of care medicine at Soba University Hospital, professor of medicine, University of Khartoum. We are doing our sessions in basic emergency care course. This is the third session in difficulty in breathing, and in this session we are going to discuss how to manage patient with difficulty in breathing. The main objective of this session is how to manage patient with difficulty in breathing. Remember that to treat ABCDE problem first and life-threatening condition. You treat life-threatening condition and ABCDE first before you go to sample history and secondary survey. Management of suspected airway inflammation or burn. Try to keep the patient calm. Give oxygen as tolerated. If there is no other injury, it's better you keep the patient in a sitting position. Those with airway inflammation and burn are at risk of quick and rapid complete airway obstruction. So they need very close monitoring, and it is very critical to decide about the intervention. They might need early intubation or tracheostomy. And you have to assess if you are capable to do this in your setting or you have to hand over the patient. Patient with suspected choking, use age-appropriate chest thrust or abdominal thrust or back blow. For pregnant lady, you're going to use chest thrust, while for the other, you're going to do abdominal thrust. I'm going to put link in the comment showing you how to do the Heimlich maneuver. For choking in infant, alternate between 5 back blow and 5 chest thrust. In the comment, you will see a link on how to do this maneuver. Patient with suspected allergic reaction, remove allergen if possible. For severe allergic reaction with difficulty in breathing, give intramuscular adrenaline without delay and you give oxygen. Patient with suspected asthma and COPD, use beta agonist salbutamol plus oxygen and steroid. In patient with suspected difficulty in breathing and fever, you have to consider antibiotic as soon as possible, and with poor perfusion you need to give IV fluid for resuscitation. Patient with suspected heart attack, you give aspirin, and if they are hypoxic you give them oxygen and nitroglycerin if the blood pressure allow. Those with severe anemia, you can you have to identify if they're in heart failure. Sometimes you need to give diuretics and you have to prepare for blood transfusion. Patient with diabetic ketoacidosis, they need fluid resuscitation, they need insulin, and they need electrolyte management, and if there is concomitant infection that need to be treated. In all these conditions, you need to see if your setting can allow this management or you have to transfer. Patient with suspected opioid overdose, you can resuscitate with bag valve mask. You have to do ventilation and you give naloxone as antidote. Those with large pleural effusion and hemothorax, you give oxygen and you have to prepare for chest tube placement. Patient with chest trauma, prepare to give oxygen. If there is tension pneumothorax or cardiac tamponade, they need IV fluid. For tension pneumothorax, you have to do needle decompression and you need to prepare for chest tube placement. Cardiac tamponade, they might need pericardiocentesis. Treat sucking chest wound with 3-sided occlusive dressing, and there will be a link to a video showing how to do that. Sickle cell patient with acute chest syndrome, they need oxygen, they need good hydration and IV fluid, and they might need blood transfusion. If there is infection, they might need antibiotic treatment. Disposition of patient, ongoing monitoring is needed. Those who need salbutamol, we need to know that this drug can last for 3 hours, so repeated doses could be needed. Severe allergic reaction can return when adrenaline wear off. So during transfer, if it's long distance, you need to have extra doses. Naloxone can last for only 1 hour and repeated doses could be needed. Following submersion injury, a person may develop breathing problem later. So remember, these patients need to be monitored closely. Transport consideration: never leave patients who might need definitive airway placement and monitor during handover. Make transfer arrangement as early as possible for any patient who might require assisted ventilation. You have to assess if your facility is capable or you have to send this patient away. Take home: perform ABCDE first, identify and treat life-threatening condition, then go to sample history, then go to secondary survey and do extended examination, identify the causes and treat accordingly, and always think about disposition and transfer if you are capable to treat in your facility or you have to send the patient to another place.